Okay, good afternoon, everyone. Welcome to the next edition of the Center on Aging and Health Scientific Seminar Series. We got about 15 people here in the room, and I hope many more who are joining us remotely today. I'm David Roth, the director of the center. I just want to make a brief announcement, and then I'm going to turn it over to Jeremy Wolston, who will introduce today's speaker. But I just want to announce the good news that we have the next seminar speaker. We have a speaker lined up for Monday, June 6th. And coming to us all the way from Accra, Ghana in Africa is Professor Christopher Charles Mate-Kole. He's the director of the Center on Aging Studies, actually the founding director of their Center on Aging Studies at the University of Ghana, has training in Europe and in the United States as a clinical neuropsychologist, and is going to talk about the elderly in sub-Saharan Africa, the case of Ghana. This is one of the collaborations that we built in our International Associations of Aging Working Group. So I know June gets into summer, but hopefully most of you will still be around, and I would love to have as many people as possible come to hear Professor Mate-Kole talk to us about aging in Africa. So to introduce today's speaker, I'm going to turn it over to Jeremy Wolston.
Thanks, David. Today it's my pleasure to introduce Dr. Todd Brown, good friend and collaborator for many years. Todd is a professor of endocrinology and also of epidemiology. He has a PhD in clinical investigation as well as an MD. He has been an important member of our Pepper Center leadership team over the last several years, leading the clinical translational core, and also importantly engaged in the Institute for Clinical Translation Research, ICTSR, right, and has been really instrumental in helping us connect to that program and its amazing resources for clinical research. So Todd has deep expertise in both metabolism and HIV research, and is going to talk to us today about frailty in people living with HIV and accelerated phenotype. So Todd, take it away.
Thanks, Jeremy. I'm delighted to be here and actually talking to people, in 3 dimensions. It's really pretty special. So this is my first talk since the pandemic in person. Many Zoom talks, so this is fun. And I'm just trying to take a look to see who's online here. Great, good turnout online. So I'm an endocrinologist. My specialty is metabolic complications in HIV, and over the last 5 or 6 years, it's been clear that trying to understand metabolic complications is really trying to understand aging and HIV. And I've been engaging more and more with the Pepper Center and looking at physical frailty in people living with HIV. So I'm going to talk a little bit about that research and sort of where we are with frailty. And I put here an accelerated phenotype because there's actually, let me see if I put a question mark here because it's actually still a hypothesis. Is it really an accelerated phenotype? And we'll come full circle at the end and talk about it, what it means to be an accelerated phenotype. So here are my disclosures. So I really don't have to talk about people who lived through the 80s. HIV and AIDS was one of the biggest, if not the biggest, health concern, biggest killer of young people in the 80s, particularly affecting gay men initially and IV drug users a little bit later, and then to heterosexual men and heterosexual women. Really a huge issue from a healthcare standpoint. At Hopkins, this is Frank Polk, who was an infectious disease doctor and saw this happening in 1982, and was talking to John Bartlett, who some of you may know is the chief of infectious disease for a long time. And this is the conversation that they had in 1982 as recounted by John Bartlett before he died. So Frank Polk says, I'm going to pursue gay-related immunodeficiency disease. And John Bartlett says, what disease? There are 7 patients. And Frank Polk said, this is going to be a big one. And right he was. So before the causative agent of AIDS was known, the multi-center AIDS cohort center study was created, and 4 sites in Baltimore, Chicago, Pittsburgh, and Los Angeles. And it was with all men who have sex with men, some who were found to have HIV, many through the study actually, because that's where they could get tested. And since that time, they've been followed at semi-annual visits. So the reason I tell you this is I'm going to be, I've been working in the MAX since my fellowship, and a lot of the data I'm going to be presenting you comes from the MAX. And more recently, we combined with our sister cohort called the WISE to become the MAX-WISE combined cohort study. So things have changed dramatically, and this was in the care of HIV. Really, in the last 50 years, it's hard to imagine a bigger success story in medicine than that of HIV. What was uniformly a fatal disease became a chronic disease really super quickly, and the threshold period was in 1996 when combination antiretroviral therapy came around, suppressing viral load completely, recovering immunologic parameters like CD4 cells. And you can see this quite graphically on this slide, very famous, actually the most cited paper on all of HIV medicine. So you can see with the advent, with the advent of combination antiretroviral therapy, here with the initial antiretrovirals with protease inhibitors plus 2 other medications, there was a rapid uptake where it was available. It took about 10 years or more for it to be available around the world, including in sub-Saharan Africa. But in places where it became available, you see this big decline in the death rate. And so with this, as people were doing well with their HIV, people were living longer. And we have seen this. There we go. And this is just over the last couple decades, the number of people with HIV in the US who are over 50. And you can see there's a steady march upwards. And so we hit back in 2017 over 50%. So now it's about 55%, 56%. And you can see this really well looking into the future. This is from the Netherlands, but Carrie Althoff has some nice data from the US as well. And you can see here, this is the proportion of people in each of these age groups, with the yellow being 70 and older, and this color here, this green here being 50 and older. So above here is 50 and older. So back in 2010 in the Netherlands, 30% of people in the Netherlands with HIV were 50 and older, with a small sliver who were 70 and older. And from projections, based on how people are doing, it's the demographics are going to change quite a bit. By 2030, a full 70% of people with HIV are going to be 50 and older, with about 10% being 70 and older. So here we have this graying of the HIV population. There is, however, a mortality gap still. And so this is data from Denmark. And the black line here is the people without HIV in the Danish population. And this is the survival in people with HIV in various timeframes here. And with the latest being 2014, you can see that the median survival increases steadily, but you still get this gap between the people with HIV and the people without HIV. So the gap is closing, but the gap is still persistent. You also see a higher burden of comorbid disease, aging-related comorbid disease in people with HIV. And I listed a few of them here: diabetes, cardiovascular disease, chronic kidney disease, cognitive dysfunction, osteoporosis, and hypogonadism. Of course, these are happen with increased frequency in aging. And if you look at these various comorbidities, this is from a cohort in Amsterdam called the Age HIV cohort. the red are people with HIV, the blue people without HIV. Pretty much for every one of these comorbid diseases, the red bar is higher than the blue bar, suggesting a higher prevalence of these comorbidities. And if you add these comorbidities up, you can see that there's more red and orange in the people with HIV compared to the people without HIV. You know, see, and with increasing age as well, really at every age category, more comorbid disease. So you have this issue of multimorbidity. So in the MAX cohort, we see the same thing. And so over the years, in collaboration with other investigators in the MAX and some of my mentees, all of these common comorbid conditions have been found to be higher in incidence in our men with HIV compared to the men without HIV. So now, as I mentioned, we're combined with our sister cohort, and we've added a whole bunch of sites. So 13 clinical research sites. The data analysis and coordinating center is here at Hopkins. And so we were established right before the pandemic. So as you can imagine, it was sort of a rocky beginning to our cohort, but we're sort of hitting our stride now. And so I'm going to be showing you some data from the NWCCS. And this I wanted to show you, looking at multimorbidity, similar to plot to what I showed you before. Here, blue is the number of comorbid diseases. You can see the dark blue is five or more. And you can see here, when you're comparing the people without HIV compared to the people with HIV, lots more of the dark blue overall in these heat maps. And what I really wanted to show you here, which has a lot of implications, is that there's more of the dark blue in the women. So there, you know, for both males and females, the people with HIV have more comorbid disease compared to the people without HIV, but it's even the difference is even greater among the females. And so why that is and what the implications are is really important. And you know, like a lot of diseases and conditions in medicine, women get the short end of the stick in HIV research as well. And so this is a really important gap in our knowledge. Yeah. That's true as well. Yeah. So yep. But the different, yeah. So it's tough to show the interaction. You know, you can see the p-value on that interaction there. But yeah, if you look at the delta between, you have to sort of cross from the people with HIV versus not there. That difference is greater between the blue on the left and the blue on the right. But yeah, so the HIV, because totally different risk factor profile. So in the Ys, you know, in the MAX, it started as mostly white men. In about 2001, 2003, we made a concerted effort to get Hispanic men and African American men. In the Ys, it's almost all African American women and Hispanics. So they're about 70 or 80%. So very different, even though, you know, they're men and women together. And this is the challenge. I mean, you adjust just for race here, but there's some residual differences as well. So what are the causes of comorbid disease? And I just wanted to briefly just give you a bird's eye view. So you have patient factors, and you know, so things like other comorbid diseases, age, race, as we've talked about, other risk factors for the disease at hand. You have HIV disease-related factors, and I'll talk quite a bit about inflammation and chronic inflammation because it's very relevant to the frailty story. And then medication factors. So I mentioned how well these medications work, but the initial medications were actually quite toxic. People developed a lot of metabolic toxicities, and that's how I got interested in the area. The medications have gotten a lot better, but some of the medications continue to have some problems with them. And there are legacy effects of medications that were given years ago, even though people have been off of those medications. So what's the story with frailty in HIV? And so the first glimpse of this was back around early 2000s. And this was we didn't have in the max anyway, grip strength and walk speed. And so what we did is, or I wasn't involved in the research, so Joe Margolick led this. And so he created with Loic Descabe, who was a PhD student at the time, looking at a frailty-related phenotype where there were 4 criteria rather than 5 criteria. And so the weakness, the grip strength wasn't available, but they got decent approximates based on the questionnaires that had been done for years and years regarding exhaustion, slowness, low physical activity, and the physical shrinking. And so it was considered 3 out of 4 of these criteria was considered frail, and they calibrated to the CHS to look at so that they chose the cut point so that the age matched in the HIV negatives, the age matched group in CHF would have about the same prevalence of these problems as same prevalence of frailty. And so there was a series of papers in the late 2000s looking at this FRP. And what they found was that the men with HIV who are 5 years old, so average person 55, had about the same prevalence as a 65-year-old. And with the prevalence increased, or the odds of being frail increased with the duration of HIV infection. And they went on to make a few observations. One is that the duration of HIV infections, I showed you here, that the CD4 cell count in both the pre and post-heart eras was associated with frailty. So immune dysfunction was associated with frailty even back then, the frailty-related phenotype. And then they looked at survival. This frailty-related phenotype was associated with survival after the initiation of antiretroviral therapy. So in 2006, the MAC started gathering data about frailty, so doing grip strength and walk speed in addition to the subjective measures. And these are data from Jen Schrack, who some of you know. And so Jen looked at the longitudinal data, both in grip strength and walk speed. And what you see here is you have age on the x-axis. The graph on the left is gait speed. Graph on the right is grip strength. Blue is the men without HIV. Red is the men with HIV. So of course you get declining grip strength and walk speed with increasing age, but the decline is faster in the men with HIV, and the decline in grip strength is faster in men with HIV, suggesting an interaction. Yeah.
One of the comments for questions that are asked.
Oh yeah. Good point. Yep.
And these were adjusted.
Yeah, exactly. And it's always tricky what to adjust, how to exactly adjust for that. And so do you do a comorbidity count? Do you put in the comorbidities separately? And Jen played around with both of those strategies. And Carrie Altoff in epidemiology then looked at frailty per se in the MAX when there was enough data to really look at it. This is the proportion of visits where there's frailty, and you can see the open circles are the men without HIV, the diamonds are the men with HIV, and what you see that after about age 50, the prevalence is higher in the men with HIV compared to those without. And we're seeing this around the world. And so these are data from the age HIV cohort that I mentioned. So similar, they stratified by age here. So you can see the frail in the dark versus HIV positive versus HIV negative. And you can see at every age, the prevalence of frailty is higher in the men with HIV, or the people with HIV versus not. This cohort is mostly men. It's about 85% men, if I'm getting that right. And so you can see that when you look at the 5 different criteria, you can see the people with HIV have higher prevalence pretty much across the board. The closest you have is the physical activity criteria. So why is this? And so many of you recognize this from the many papers that you've written. In fact, this comes from one of Jeremy's papers. And so here you have the clinical manifestation. And what I wanted to do is talk about some of the physiologic changes that you see in people with HIV, and then end with some of the molecular changes, or a glimpse into the molecular changes, because I think that that's where the field is going. So HIV, of course, is an inflammatory disease. And so inflammation plays what we think is a causal role in many of the comorbidities that we see in conditions, including frailty. I also I'm going to talk a little about neuroendocrine dysregulation. I'm an endocrinologist, so that's sort of how I got into this field, specifically looking at IGF-1 and sex steroids. And I also want to talk a little bit about glucose metabolism. So let's talk about inflammation. So if you look at markers of systemic inflammation prior to when someone starts antiretroviral therapy, they're very high. You know, whether it's IL-6 or TNF-alpha receptors. And so, and when you initiate antiretroviral therapy, these marker levels of systemic inflammation decrease, but don't decrease to the level of a person without HIV. And so this is a study that we did looking at these markers with antiretroviral initiation, getting the viral load undetectable. And you can see that there's a profound decrease. And for soluble TNF receptor 1 tends to go back to baseline. Receptor 2 state goes down and stays down, but still not to where you would expect in a person without HIV. So here's the reference ranges below. We've done other studies looking at inflammatory markers, comparing people with and without HIV. This happens to be a study we did about sleep apnea. I'm just showing you the inflammatory marker data. We did. So this is the difference compared to the HIV negative group. We had two groups with HIV, one suppressed on antiretroviral therapy, the other not on antiretroviral therapy. And this is the percent difference. And so you can see for TNF itself, big, really high levels of TNF alpha in those without antiretroviral therapy, comes down to lower levels, but still significantly different from the people without HIV. You can see TNF receptor 1, receptor 2, actually no difference in IL-6, but that was just probably a sample size issue variation. So you have this elevated inflammation even with good antiretroviral therapy. Yeah, slightly. People can't see me if I move over here. So yeah, so this the difference here is not statistically significant. In between, the asterisk is because is comparing against the HIV negative group. So back to the theme about the difference between men and women, what's emerging more recently is that systemic inflammation is actually higher in women compared to men. And you can see all of these markers here, pretty much with the exception of IL-18, are higher in the women with suppressed viral load compared to the men with suppressed viral load. And you can see, here's receptor 1 and 2, or receptor 2 here. ICAM, soluble CD163 is a monocyte marker. The KT ratio, which the Frailty group here has looked into quite a bit, is higher in women compared to men. LBP, IL-6. And importantly, what this study did is looked at a composite event of deaths and type 2 diabetes. And the predictive value of these various inflammatory markers looking at different pathways seem to be better in the women compared to men. So inflammation may mean more in women compared to men, and that's an emerging story. So what about inflammation and frailty? So we looked at this in a case control study in the MAX, where we had 3 groups. We had men who had this frailty-related phenotype, who were HIV positive, men who were HIV positive who were robust according to the FRP, and men without HIV who were also robust. And so you can see the first panel is looking at frail versus non-frail. The second is just among the non-frail looking HIV positive versus negative. And what I want to draw your attention to are these markers. So TNF receptor 1, borderline statistically significant difference, but IL-6 and CRP really quite different between the frail and the non-frail, as you would see in the general population. And you can also see different levels, compared to HIV positive versus negative, who are both robust with higher levels of systemic inflammation. So obviously, I'm going to come back to this one. These levels of inflammation also predict mortality. And some of you, I think Jeremy and Karen, you were involved in the study of Damani Pickett in the ALIVE study. For those of you who don't know, the ALIVE study is a study that has been going on since the late 80s in Baltimore, looking at injection drug users, about a third of whom have HIV. And what doesn't really project very well, but what Damani showed here is that the levels of IL-6, TNF alpha receptor 1, and inflammatory score based on a combination of those two were associated with frailty independent of HIV status. And that the higher levels of inflammation, and this is an inflammatory score of IL-6 and TNF receptor 1, were associated with increased mortality over time. That's what this red line is. So where does this inflammation come from in people with HIV? And so there are really three pathways that people think about. One is microbial translocation, which is nothing specific to HIV, but I'll talk a little bit more about why it's a little bit different. So this is bacterial products coming across the gut, causing systemic inflammation, to immune system that's sort of waiting. There's another potential, although the viral load is undetectable when people are in antiretroviral therapy, there's low-level replication of viruses happening, and there's an inflammatory response to that. The third is potential co-infections, and one of them, especially around Baltimore, that we see with injection drug use is HCV. Fortunately, there are good treatments for HCV now, so we're not, hopefully we're not seeing as much HCV co-infection related things. One of the big emphasis now is, as in the general population, is looking at CMV and cytomegalovirus to see how that immune response might be driving some of the inflammation that you see. So the microbial translocation story is pretty interesting, and I want to share with you a study that was presented at our big meeting called CROI a few months ago. And so in this study, just some background here about the gut barrier. So here's a cartoon of the gut and the lining of the gut, and then enterocytes here. This is the luminal side. This is the basolateral side. So you can see that you have a rich immune environment in the gut with CD4 cells, CD8 cells, and Th17 cells, providing a barrier for products coming in. Very quickly in HIV infection, really in the first couple of weeks, there's a depletion of immune cells in the gut, with depletion of CD4 and CD8 cells and Th17 cells as well, which set up this sort of leaky gut type picture. And the tricky thing about this, a lot of things in HIV can be improved if we start therapy earlier, if we find people with HIV with acute infection and treat them early so their CD4 cell count doesn't drop. It suggested that this is not one of these things, that this is an immune defect that happens very quickly, and even with a rapid initiation of antiretroviral therapy, this doesn't reverse itself. So this is this leaky gut kind of phenotype that you get. So decrease in tight junctions, intestinal permeability, so these bacterial products can come across the gut and lead to systemic inflammation. So to test the hypothesis of how this may be causing systemic inflammation, and particularly whether it leads to vascular inflammation, Janet Lowe, who's at Harvard, used a GLP-1, GLP-2 peptide. So GLP-2 is a hormone that's released by the gut. GLP-1 is its more famous brother. GLP-1 is now used as a very common treatment for diabetes because it has endocrine effects, causing insulin release from the pancreas, decreasing glucagon, et cetera. But GLP-2 sort of stays right at the border of the intestines and restores the intestinal epithelium, promotes mucosal healing, and it's used for short gut syndrome. So it's FDA approved for that purpose. So what Janet did using teduglutide, she randomized people to test the hypothesis if you can give this GLP-2 molecule to people with HIV, can you decrease systemic inflammation? And can you decrease vascular inflammation as well? And so here's the cartoon of what the hypothesis was. So you have this leaky gut here. You give the teduglutide and you restore the gut. This reduces systemic inflammation, immune activation, and reduces CV inflammation. She didn't have any frailty related or muscle endpoints, but this would be something interesting to do. And it's quite a small study, proof of concept study, 17 and 15. You can see mostly male, so getting at this theme of not enough data in women, and also not enough data in people who are not white, also an important limitation of data. So over a relatively 6-month period, relatively few people. But what she found, she used a marker of arterial inflammation, the carotid artery, with FDG PET, and saw a significant reduction in arterial inflammation by FDG PET. You can see the treated versus placebo. And she also found a decrease in activated monocytes, a decrease in activated CD8 cells. So it's both on the innate and adaptive immune system. So that this drug works. So really driving home the hypothesis that the leaky gut is really causative for some of the systemic inflammation that you see. I want to highlight the work of Joe Marglich and Sean Lang from Hopkins, who really looked at this at CMV specific inflammation and showing correlates with frailty in people with HIV. So CMV may be an important, as in the general population, may be an important driver of inflammation. And now there's a big study that's ramping up with letermovir to eradicate CMV, hopefully decrease systemic inflammation. And there's actually a physical activity sub-study with that. So that's the inflammation story in a nutshell. And I want to talk a little bit about the neuroendocrine dysregulation and then glucose metabolism. So here is the same study that I showed you before, the case control study. And here's looking at different hormones. This is DHES, which is an adrenal androgen, free testosterone, IGF-1, which is sort of the end product of the growth hormone axis produced by the liver, and then HOMA-IR, which is a marker of insulin resistance. And what you see is that when you look at frail versus non-frail HIV, the men who are frail have lower DHES, so potentially lower adrenal androgens, lower free testosterone. We'll be talking about more of that in a second. IGF-1 was no different, but IGF-1 is not a great marker. If you really want to know about the growth hormone axis in humans, you need to do growth hormone specific studies, and I'll show you some of those. And then HOMA-IR, higher HOMA-IR was associated with this frailty related phenotype. So glucose metabolism seems to be important. So I'm going to take a quick detour into body composition changes, and I'll tell you why in a second. It'll become obvious. So soon, this is sort of where I got into this field, is that people were in the late 90s, people were doing really well from an HIV standpoint, but they were developing all these endocrine problems and the glucose problems, cholesterol problems, and body composition changes. And these body composition changes came in two flavors. One was lipohypertrophy, so fat expansion, and the other, or lipoatrophy, fat diminution, and lipohypertrophy. And so I'll show you some pictures in a second. So here's lipohypertrophy. generally increased visceral fat in the abdomen. Sometimes there were lipomas in the neck, so-called buffalo hump or dorsocervical fat pad. There could be a lipoma up here in the occipital fat pad. There could be lipomas in the suprapubic areas. So lipomastia, so breast enlargement from increased fat. And so these cases in the late 90s were reported more and more. And it's probably a multifactorial etiology, but I'll cut to the chase and then come back to it, is that one of the issues here is abnormal growth hormone dynamics. The lipoatrophy story is quite different. So here you get wasting of the fat. And so patients often complain of not some that their legs are getting skinnier, but their veins are bulging. And it's not because the veins really have changed their size, it's because the surrounding fat has decreased, so the veins appear more prominent. And and you can see in particular in the face, this facial lipoatrophy that people can get. You can see this nasolabial fold is really pushed in. This buccal area is wasted. You can see some temporal wasting here as well. And so these two problems, initially they were thought to be related, but it's pretty clear they're separate. The lipoatrophy is caused by the NRTI regimens, particularly thymidine analogs, and they're mitochondrial toxic. And they cause mitochondrial disruption in fat cells in particular with apoptosis and sort of an inflammatory phenotype in the fat itself. The lipohypertrophy story is a little bit different. And I just want to show you the MRI just to see normal versus abnormal. So this is normal fat distribution with the white here is the surrounding subcutaneous fat. You see a little bit of visceral fat here in white. This is someone who has combined lipoatrophy and lipohypertrophy. You see a lot of the white in the inside. This is visceral fat, and the subcutaneous fat is barely perceptible. So a lot of fat wasting. So this is what we call mixed lipodystrophy type picture. And even after people have been off of offending drugs, I mentioned those thymidine analogs, and this is a study that we did in the MAX. People stop being on the most offending drug, stavudine, in about 2004 in the US. But you can see that the fat comes back a little bit, but it doesn't come back to baseline. So at every BMI category, the people with HIV, the men with HIV, have lower subcutaneous adipose tissue compared to the men without HIV. And if you look at the visceral adipose tissue, you can see that the orange here, the men with HIV have higher amounts of that, particularly those of normal weight and those who are overweight compared to people without HIV. And this increased central fat is associated with frailty. So here's a study that we did in the MAX looking at HIV positive and HIV negative, looking at various body comp elements, and I want to draw your attention to the fat aspects of things, and particularly the BMI. So this is robust versus pre-frail, robust versus frail. And BMI is really not associated, higher BMI is not associated with frailty, but an increased waist circumference and increased visceral fat is. And so this tells us when we're thinking about body composition and frailty, BMI is probably not a good way to go. We really need to be doing more specific studies looking at where the fat is and really what the fat function is. So I started talking about the growth hormone axis, and this is where the detour swerved back onto the road here. And it was recognized quite early on that these people with lipodystrophy, increased central fat accumulation, had abnormal growth hormone dynamics. And so what you see here is the best way to test someone's growth hormone axis is to do an overnight test where you bring them into an overnight clinical research setting and test their blood every 20 minutes to look at the growth hormone pulsatility, growth hormone pulses throughout the night. And you can see that this is the mean growth hormone pulsatility overnight. Let's see if I can get my thing back here. And you can see it's much lower in the people with this phenotype of lipodystrophy compared to controls, and the non-lipodystrophics are somewhere in the middle. Another way to do it is to look at a test that stimulates the growth hormone axis. In this case, growth hormone releasing hormone and arginine stimulates growth hormone secretion. And you can see that for people who fail the test based on various cutoffs, much higher in people with lipodystrophy compared to those without. So this sort of set the stage for, well, something's going on here with the growth hormone axis and lipodystrophy. And if you look at the relationship between growth hormone and visceral fat, it's completely inverse and pretty decent correlation too. So the lower the growth hormone level, the more visceral adipose tissue is. So this sort of set the stage for investigating the growth hormone axis as a way to treat central fat accumulation. And so this work was done by Steve Grinspoon at Mass General, who looked at a drug called tesamorelin, which is a growth hormone releasing hormone agonist. So growth hormone releasing hormone comes from the hypothalamus, tells the pituitary to secrete growth hormone. Growth hormone then acts all the cells in the body, but also primarily on the liver to make IGF-1. And so with tesamorelin, this growth hormone releasing hormone agonist, you over this is a 6-month study, and we were one of the sites here, you get a pretty significant decrease in visceral adipose tissue. So suggesting that by reversing these growth hormone changes, you can decrease visceral adipose tissue. And this VAT is associated with fat in other places. So fat in the muscle, fat around the heart, fat in the liver, and then fat in the pancreas. And we've been interested in fat in the muscle because various studies outside of HIV have shown that fat within the muscle is associated with frailty and fractures and bad aging outcomes. And so we looked at fat quality. You can get sort of the best way to look at it is really with an MRI, but you can give it sort of a poor man substitute looking at CT scans and the attenuation on CT scans. So the lower the attenuation, the more fat that's in the muscle. And you can see the men with HIV, really with increasing age, no change in their thigh muscle attenuation. So no change in the fat, but you have a decrease, so more fat in the muscle with age in men with HIV, and that was a significant interaction. And it turns out that if we reanalyzed the study and we reread the scans for fat in the muscle with tesamorelin, and it turns out that tesamorelin not only decreases visceral fat, but decreases skeletal muscle fat as well. Now, unfortunately, we didn't have measures of physical function with this, but it does suggest that maybe this is a useful strategy to deal with some of the physical function related issues in people with HIV that may be related to fat. And here, a cartoon showing what we see in the general population, but is perhaps quite true in people with HIV, where you have increased visceral adipose tissue, increased intramuscular fat, and then decreased skeletal muscle as well, leading to this sort of sarcopenic obesity phenotype. So back to the pathogenesis of frailty, talking a little bit about sex hormones, and I'm trying to. Yeah. Yeah. So yeah, just for people online, the etiology of the growth hormone abnormality. So in people, yeah. So really unclear, and which way what's the cart and what the horse is. And it turns out that obesity in the general population is quite a heterogeneous phenotype, and there's about 10 or 15% of people who also have abnormal growth hormone dynamics. So it may not be something specific to HIV, but it's unclear at this point. So let's talk a little bit about sex hormones. And so this is from the NHANES, looking at the prevalence of hypogonadism, using a 300 cutoff over age. And you can see, obviously, as people get older, their testosterone levels decrease, men's testosterone levels decrease, and the prevalence of hypogonadism increases. in people with HIV, it was recognized really quite early, and this is some work with Frank Polk, who I showed you before, and Paul Ladenson and Adrian Dobbs back in the 80s showed a very high prevalence of hypogonadism in men with HIV, particularly those who had AIDS. And the numbers have gone down as good antiretroviral therapy has been available, but really much higher than in the general population. And just to put some numbers on it, in the MAX, when we started looking at this, about 25% of the men ages 60 and older in the MAX were on testosterone. And that number was about 5% in the men without HIV. So really high use of testosterone, high prevalence of hypogonadism. So a couple things. One is that to know about testosterone. One is that the testosterone is a steroid hormone. It's transported in the blood, either bound on to sex hormone binding globulin or bound to albumin or other plasma proteins. And only about 2% is free. And that free fraction probably has the most biological effect. So the problem that you get into is that SHBG is higher in inflammatory diseases like HIV, like HCV. And so this suggests the free fraction can be decreased. And so we looked at this, in a cross-sectional way, men with and without HIV. If you look at total testosterone, really quite similar by HIV status, but free testosterone is significantly lower in the HIV positive compared to negative, and this is related to the SHBG being higher. And if you look in a cross-sectional kind of way, and you look at the age versus the age coefficient versus the testosterone coefficient, the HIV coefficient, you can see that with increasing age, free testosterone is lower, and that difference of the HIV effect is equivalent to about 13 years of aging. So we did a little more precision here, and we did a longitudinal study over 10 years and measured men with HIV versus men without HIV with multiple measurements over time in the MAX. And what we found is so look at the blue line here and the red dotted line, that's HIV negative versus HIV positive. In both the HIV negative and the HIV positive, there's a decrease over time. And this is about what you see in the general population, about 1% a year decrease in free testosterone. But there was this persistent difference between, it's suggested by looking at HIV. But this is really only true if you look at the morning samples. So what you need to know is that testosterone peaks at about 8 a.m. and has its nadir at about 6 p.m. And so we have about a third of the measurements were done in the afternoon, the rest were done in the morning. And so you can see this difference between AM and PM for free testosterone was significantly different. And you can see the difference by HIV status. It was really interesting because we separated the AM draws versus the PM draws, and something interesting emerged. And so what you see here is the HIV negative. So up here is the AM draws, and these down here are the PM draws. This is HIV negative. So you see this big difference between AM and PM. So this is suggestive of normal diurnal variation. And with aging in the general population, one of the characteristics is a blunting of this diurnal variation. So the difference between AM and PM shrinks. And you can see that here. You can see the 80-year-olds here, very little differences, the ratio between AM and PM, very little difference compared to the 30-year-olds where there's quite a bit of difference. And so check out the HIV positive group and the difference between the AM and PM, really quite a bit of difference, and not so much that the PM has stayed the same, but the AM has come down. And if you just look at the AM values, there's a significant difference by serostatus. So what this suggested to us is that maybe there's a blunting of the normal diurnal variation characteristics of aging. So is this aging of the gonadal axis in men with HIV? And there's some reason to suggest that inflammation per se can impact the axis in that way. If you give TNF alpha, for example, to healthy volunteers, you'll get a suppression of normal gonadal dynamics based on the diurnal variation. So this is a hypothesis that we're testing. Some of you may know Jenny Pena-Diaz, so hopefully her K will get funded, and we have measurements in the same person in AM and PM, and we'll be able to look at this in a more rigorous way. We also want to look at frailty specifically, and whether the free testosterone and also the sex hormone bonding globulin can predict frailty. Yeah, absolutely. Yeah, probably. Yeah, definitely. So cortisol, for example, another hormone that has clear diurnal variation. Less so, cortisol doesn't have this, the same, it mostly has an effect by, stress, as you all know, rather than pulsatility overnight. The other important thing here that can impact, and this is true in the general population as well, is sleep. So you need to have a normal sleep-wake cycle in order to get that increase in morning testosterone. That's another issue that we're investigating. So talk a little bit about glucose metabolism. Just to say that it's important. So this is a paper that actually was part of my PhD thesis, looking at risk of incident diabetes in the max over the early time period. And this is HIV negative. These are proportion who remain free of diabetes, and you can see the HIV positive on antiretroviral therapy. And when you do the adjustments, there was a 4-fold increased risk of incident diabetes in our men with HIV compared to those without. Suggesting that the glucose problem. We looked at this further, and it's mostly an insulin resistance issue. I won't get into it. Some of it is related to the body composition changes that I showed you before. Some of it is related to the medications, which has changed over time. Inflammation seems to play an important role. Here we looked at measures of systemic inflammation 48 weeks after antiretroviral therapy initiation. So this is a time, usually people become suppressed with their viral load before 24 weeks. So by 48 weeks, you're definitely suppressed. And we only looked at suppressed people. But the level of inflammatory marker 48 weeks after initiating antiretroviral therapy predicted incident diabetes later, suggesting that it is an important factor. And diabetes, particularly uncontrolled diabetes, is important. As you all know, in the general population, with the work that you've done in WAS and other places, that an important predictor of frailty characteristics. Here we looked at grip strength and gait speed, and it was really the uncontrolled diabetes that seemed to have a big role in grip strength in particular. And just looking at the coefficients, if you can do that, so it was a pretty robust effect, equivalent to about 9 years of age. And you can see here, I'll just highlight it, DDI is one of these mitochondrial toxic drugs. Even though people haven't been on these drugs for years, does suggest that exposure to DDI, the cumulative exposure to DDI, has effects on grip strength. This is one of these issues where there are legacy effects of these drugs, even though people have been removed from them. So I don't have time to really get into the molecular side of things, but I think this is where the field is going. And so oxidative stress, mitochondrial deletions, I alluded to that, shortened telomeres, DNA damage, cellular senescence. So all of these have been shown to be more pronounced in people with HIV. So Jing Sun, who some of you know, her K is going to focus on some of these mitochondrial toxicities, looking at mitochondrial copy number as a surrogate. Cellular senescence is obviously important as well, and really is characteristic. And one of the aging-related phenotypes that you get in people with HIV is immune aging. And so I just want to show you this panel from the same study, same case control study that we did. These are CD4 28 negatives, that's a senescent marker, and CD8, 28 negatives, that's a marker of cellular senescence. And HLA-DR and CD38, that's a marker of immune activation. And so this is compared to HIV positive versus negative. And you can see much higher values, both on the activation side and the senescent side. So these senescent cells, of course, as in the general population, are productive of lots of inflammatory cytokines. They're dysfunctional and probably drive some of the immune dysfunction that you see. So this gets back to the other question, the question that I posed at the beginning. Is it really, is it accelerated aging or is it accentuated aging? The distinction being accelerated, so it works through the same pathways as we think aging works through, or is it just accentuated aging being another risk factor for physical frailty, like diabetes would be, or like COPD, or like congestive heart failure? And so it's because, looking at the previous diagram, some of these sort of core tenets, the pillars of aging that we see seem to be abnormal in people with HIV and seem to be abnormal at an earlier time point, earlier, chronologic age, that it is, I think, an accelerated aging phenotype. But there's clearly a lot to be known. And part of the issue here is the people that were studying, and also in contrast, the people who were not studying. And so the max and also the Ys is a survivor cohort. So these are guys who were recruited in the cohort in the 80s, and a large chunk of those guys died along the way before good antiretroviral therapy came around. And so, these guys a lot of them have been through the ringer. They've seen a long period of time when their HIV was not well controlled. When the antiretroviral therapy came around, they started on it, but the antiretroviral therapy was pretty toxic. And these, as I mentioned, the toxicity of these drugs continues even today, even though they've been off of it for 15 or 20 years. And so here you have two patients. They're both the same age. They have the same current antiretroviral therapy. They have the same CD4 cell count, a good CD4 cell count. Both their viral load is undetected, but their histories are quite different. So this guy has HIV since '87, a very low nadir CD4 cell count, so below 200 is considered AIDS. Started AZT in the early 90s when it became available. Started good combination antiretroviral therapy in 1997 when that became available, and went through a whole bunch of previous regimens, including some of these metabolically toxic regimens. Now, patient B, so he has only been infected since 2014. He started at a relatively high CD4 cell count, and started, pretty promptly on the same regimen. So wasn't exposed to these toxic antiretrovirals. And so one of the big questions is how much of this aging phenotype are we seeing is related to this history. So prolonged uncontrolled viremia for a long period of time, exposure to toxic antiretrovirals. And so will patient B also have some of the accelerated aging that we see? And we just don't know, since we don't really have a lot of patient Bs. And so our enrollment, we're doing an enrollment now in the MAX in the Baltimore site. And we're going to be shooting for this kind of person. So people that are similar to the guys in our cohort who were infected back in the 80s, but haven't been exposed to some of these toxic regimens, started with a higher CD4 cell count. So this is, I think, is one of the big questions. Now, what I showed you before with the bacterial translocation through the gut and that whole picture, because it happens so quickly, that depletion of CD4s in the gut, this person B probably has that as well, even though they started at a high CD4 cell count. So, so there still may be inflammation, residual inflammation, even if you start a high CD4 cell count, and the antiretrovirals, probably don't play as much of a role. So there are a whole bunch of different challenges for aging people with HIV, and this is an area that I think is really important. And I'm glad I see Thomas Laskow on the call. So Thomas is interested in the clinical care of people with HIV, and older people with HIV. And we really do need to be taking a geriatrics approach to some of these patients. So here are some of the major challenges that we see with multimorbidity: access to geriatric care, navigation, mental health, social services, disability, bias in long-term care, which really hasn't been reckoned with. Having someone with HIV at assisted living, is something that people aren't used to. Then, of course, there are big health disparities by race and sexual minorities that play a role. And so the face of age really has changed quite a bit. This is a famous picture that was done in the late 80s. So young person in the prime of their life, really struck down. And the face has changed. This is the founding member of our National Community Advisory Board, who I have permission to show this to you. So those are his long list of problems. Those are his long list of medications, and the ones at the bottom are his antiretrovirals, so relatively small compared to what else he's on. And his age in this picture, 55. So at CROI, this is Carl Diefenbach. He reports to Tony Fauci at NIAID. This was an interview for Dr. Diefenbach talking about highlights from our big HIV meeting. And one of the themes was aging with HIV. And Dr. Diefenbach, this is an important quote: "The care of people with HIV has not kept up with the reality of aging population." So this really is a critical area, and I think one that there are a lot of questions and that we need answers to. So in conclusion, chronic HIV is an inflammatory state driving this high burden of aging-related diseases and conditions like frailty. You have neurohormonal dysregulation, as I showed you, problems with glucose metabolism, probably also playing a driving force in frailty and possible targets for intervention. And the mechanisms underlying frailty, sort of on the left part of the frailty cartoon, are really perturbed in people with HIV. And this accelerated phenotype really has important implications for the long-term health of this population. So I will acknowledge my people I've worked with. This is mostly from the Max, Adrian and Wendy Post, people from the School of Public Health, Joe and Lisa, Ali, Jen Track, Carrie Althoff, Sabine Haberlin, Derek Ing, people from outside of Hopkins who work in the Max, Frank Palella, Larry Kingsley, Jordan Lake, Christine Erlinson, the share staff, that's our Baltimore site of the Max Wise, and our Max Wise participants. So I'll end there and be happy to take any questions. So let me go to the chat here. DTT. Oh, yeah, there was a question about repeating the question. Hopefully I did that. I'm not sure if I did. I think that was it. So any questions, you can either speak out. I think we can hear you. Or put it in the chat or here.
That was great. Really sort of as you were going to the middle of your talk, I found myself thinking about the resilience study that we're doing, our long-term hypothesis about physiology and frailty. And so, of course, the systems that we hypothesize to be involved include inflammatory regulation, but also going on in the system and HPA axis. So I'm curious to think on cortisol regulation or heart rate variability.
Yeah. So for people online, Karen asked a question about other neurohormonal dysregulation. So the HPA axis, so the adrenal axis, and also sympathetic activity. And so not as much, certainly not related to frailty. And I think that that's really an opportunity to explore. So looking at the HPA axis and stress hormones, trying to understand how stress hormones may be different, and there is some suggestion that they are different in people with HIV. looking at potential, the big question is, how you measure it, as you guys have been wrestling with the resilience study. But I think that's a key area that needs to be studied in people with HIV and looking at it vis-a-vis frailty. The sympathetic question, I think I didn't show you the data regarding sympathetic activity and lipohypertrophy, but there's some compelling literature about that actually. And we have lots of, actually a lot of heart rate variability data using Zyopatch in about 1,000 people. Lacey asked, Lacey works with Wendy Post, trying to interrogate the heart monitors they got to look at heart rate variability. And so this is something that I've always wanted to study, and I think it's an area that's ripe for more study.
So the autonomic nervous system data that you have.
Oh yeah, so the lipohypertrophy, the fat, there's some data suggesting that increased sympathetic activity is associated with lipohypertrophy, and the mechanisms there are unclear. But yeah, so I think that area of this story really needs to be told, investigated.
And the fatigue, and it seems like this same kind of
Yeah.
So we probably should try to pull people together and have more knowledge of the ultimate origins of the sympathetic nervous system.
Yeah. Sure.
Yeah.
Yeah. So for people online, the question was about, or the statement was about long COVID and how we don't really understand why people get long COVID, and how activation of the sympathetic nervous system may play a role in both diseases. And in fact, I organized a workshop, an international workshop on HIV and aging, and last year was our first year. We changed our name to the International Workshop of Long-Term Complications of HIV and SARS-CoV-2, because there clearly are parallels that need to be investigated. Let's see. So Jen has a question online. Jen Schrack, tagging on to Karen's question, do you have any thoughts of what factors may contribute to resilience in those with HIV aside from viral control? Yeah, I mean, I think it's a great question, and I think we do need to start look, as in the general population, we do need to start looking at aging through a resilience lens in people with HIV. Some of it, there's a lot of, in our cohort, we have a lot of interest in psychosocial behavioral factors that may contribute to resilience, and so things like food insecurity or security, internalized stigma, those kinds of factors that may be important in overall aging process and physical frailty. But I think that these are really important issues. Yeah. Great question. Yeah, so I'll repeat that. So, so the question is the audience member was, what's your name? I'm sorry. Elizabeth. So Elizabeth's interested in sickle cell anemia, long-term sickle cell patients, and whether there's an accelerated phenotype in this group. And the question that we wrestle with all the time in the HIV world is the comparison group. And so yeah, so the advantage of the MAX, as you mentioned, is this internal control group. So these are all people in the 80s who were at risk for HIV, and some of them happened to get it. There are some different behaviors in terms of risk behaviors, but generally drawn from the same underlying population. And so we feel comfortable in our inferences. with a caveat about survival, that kind of thing. But we feel pretty comfortable about our inferences, as opposed to you'll see studies in HIV where they compare against the general population, because that's what they have. And, you get some information about that because, the rates of these diseases important in the general population. Yeah, so trying to figure out, what is the best control population. So, you think of things like, you want to underline, get from the same demographics. So, probably, I'm just spitballing here, but I would think that unaffected siblings would be a really good control group, who come from the same environment but don't have sickle cell. But it is definitely a challenge. I mean, you need to find the population that's matched, and your table 1 doesn't show everything, right? There might be differences that they may look, on factors that you can measure, very comparable, but then on other things, maybe not so much. Yeah, it's definitely a challenge. And sometimes it's good to have, we've done this, like for this latest, we're doing a sleep apnea paper, to have 2 control groups. And so for the sleep apnea paper, we had our HIV positive, HIV negative, but we also had used the Sleep Heart Health study as an external control population to understand how different our HIV negative people are from the general population, as much as it is general population. So there's sometimes differences there as well. So sometimes multiple control groups.
Thank you so much.
Sure.
We talk about this a lot. We think about mechanisms of frailty in this population. What I wanted to ask you about was sort of what sort of characteristics for frailty, what symptoms of frailty is that?
Yeah.
Natural history.
Yeah.
What I really want to ask you about is back to this idea of primary. In this population. And I mean, are you surprised that not everyone HIV positive?
Yeah. So Brian asked a question about measurement, and which is we're all wrestling with all the time, and then about the how would you describe it? I'll answer the measurement question first. It is really tricky, and how we measure it may differ. Hopefully Amal will come in one of our frailty sessions to talk about comparing. So for exhaustion, differences by serostatus on the ways that we measure exhaustion, and then looking at more objective measurements. And so yeah, and whether or not, I mean, we don't really have a good, at least I don't have a good sense of whether some of these factors differ by HIV status, and their onset differs by HIV status. And so I think that we have a lot of data in the MAX and now the MAX-Ys to really probe that question as to what does it look like, the onset, what comes first, how do things follow, and then the other part, and I see Alden back there, how cognition interplays with physical frailty. So I think regarding your second question about how much is HIV pushing this accelerated phenotype, and this gets back to this question of resilience. There are some people who, even though they're HIV infected, they don't have high levels of systemic inflammation. They are doing pretty well, and then some people who are not doing well. And so there's a huge variability in trying to understand that variability. Now, some of it is very predictable. People who have low CD4 cell counts when they start antiretroviral therapy, and who don't have an immunologic recovery, even though their viral load is suppressed, those people tend not to have higher levels of systemic inflammation and generally get more comorbidities. But there's a lot of variation there, and trying to understand that variation is really important for 2 people who have, as I mentioned, with patient A, patient B, same parameters, but one has lots of comorbidities, one doesn't. And it could be, I presented them, I showed that as one, longer infection, versus more recent infection, but you can have two of the same exact people and have different, systemic, different systemic levels of systemic inflammation. And so trying to understand what that variability, and some of it may be related to genetics. So we've been interested in interactions, so in HIV, looking at mitochondrial haplogroups. And Jing Sun actually has a study looking at one mitochondrial haplogroup in the max is associated with a more profound decline in grip strength and walk speed. So it's something that we're exploring more.
So, great talk. I really appreciate how you laid out all the factors in terms of various medications.
Yeah.
And also like how you ended up with the 60-year-old patients, that 55-year-old that you put up with this whole list of medications. Connecting in my head, the geriatric care, we have people on the list of geriatric services, prescribed it.
Yeah.
Prescribing people with your elderly HIV people. I think that was on that.
Yeah.
That's why that would be
Right.
general thoughts about.
Yeah. So did ask a question about prescription and multi polypharmacy and deprescription, which is a really important issue. Yeah. So this is something that we've been looking into quite a bit. We have a paper showing that not surprisingly, that the more medications you're on, the more likely you are to fall, and particularly anticholinergic medications seem to be important. Yeah. So part of the issue here, and this is true in the general population, is the model of care and who's seeing the patient. And so I'm an endocrinologist, I'm a specialist. And so when someone comes to me, I give them, the medications that I think, look at their other medications, but I'm sort of taking care of that little piece of them that's related to their endocrine dysfunction. And so, and if you see multiple specialists, you tend each of the specialists put on their own different medication, and soon you're on 20 medications. And so it really is important to have that discussion. And this is where the geriatric model, I think, is important, about going through doing the med reconciliation and saying, okay, do you really need to be on that proton pump inhibitor? Do you have GERD? I mean, people are put on medications for all different reasons, as we know. Yeah, so I think there is an important movement to understand the polypharmacy and whether deprescription is viable. Some of these medications have questionable value. They're mostly symptom managing, and maybe they don't manage the symptom very well. So it is tricky. And things like that I'm interested in, like testosterone. We don't really know what the long-term risks and benefits are of testosterone. But as I mentioned, a lot of these guys that I see that are in the study and are my clinic patients have been on testosterone for 20 or 30 years. And I don't really know if I'm helping them or hurting them. And so, I think that this is an area where I'm not sure if deprescription is the best solution. And so it's something that we've been looking at quite a bit. Questions? Yeah. Yeah, absolutely.
All right, any final questions? Okay. Question from Robbie on that.
Oh, yeah. So Robbie, do 50-year-old HIV patients see geriatricians? Yeah, so yeah, good question. And I see Thomas's camera coming on.
Not currently, not at Bartlett. We're doing 65 and older, but that's a whole discussion that we just don't know. Clinically, it seems like certainly there's more comorbidity, but maybe not the 50-year-old is the right person, but we don't know.
Yeah. And how to gate people into a clinic like that, is age the best way to do it? And there are 50-year-olds and 50-year-olds. It's a huge heterogeneity in what a 50 or 55-year-old looks like. But I'm grateful, Thomas, that you're looking at this in the Bartlett Clinic. I think it's going to be really important for our patients. Thanks, everyone. Thanks, everyone online.
Remember June 6th, Christopher Charles Macaulay all the way from Upper